the pituitary gland disorders, which are mostly caused by pituitary tumors. And mostly these tumors are non-cancerous. So they make about 10 to 15% of all tumors that develop within the skull. Next. A pituitary gland is also called the master gland because it produces several hormones and controls other glands, such as the thyroid and adrenal gland. Next. So to begin with, let's talk about the anatomy and physiology of pituitary gland. It is an endocrine gland located at the base of the skull in a small depression of the sphenoid bone called sella turcica, and is connected to the hypothalamus via the pituitary stalk. And it is located below the optic chiasm, which is important to bear in mind because this carries a clinical correlation to the signs and symptoms of pituitary gland disorders in general. It has two lobes, the anterior and posterior lobes. The posterior pituitary, also called the neurohypophysis, secretes two hormones, the ADH and oxytocin. It is derived from neural ectoderm in the floor of forebrain. It contains axons and nerve terminals. Its neurons originate in the hypothalamus, so it is like an extension of the hypothalamus. It has two nuclei, the paraventricular nuclei and the supraoptic nuclei. The supraoptic nuclei produces ADH, and the paraventricular nuclei produces oxytocin. Therefore, this lobe does not produce hormones, but stores those produced by the neurosecretory cells in the hypothalamus, and the release of these hormones is triggered by receptors in the hypothalamus. Next. The anterior pituitary is a glandular tissue. It accounts for 75% of the total weight of the pituitary gland. It contains 5 cell types that make the hormones: the corticotrophs, which stimulates the release of adenocorticotropic hormone, the thyrotrophs, which releases the thyroid stimulating hormone, the gonadotrophs, which releases the LH and FSH, the somatotrophs, which releases the growth hormone, and finally, the lactotrophs, which releases prolactin. Hormones in this lobe are controlled by regulating hormones from the hypothalamus, either stimulating hormone or inhibiting hormone. Next. So as I've mentioned before, the hypothalamus regulates many other organs, such as the mammary glands via oxytocin, the kidney via the ADH, the mammary glands via prolactin, thyroid via thyroid stimulating hormone, and the adrenal cortex via ACTH. Next. The hypothalamic portal system. It is a blood supply that connects the hypothalamus to the anterior pituitary. This system, stimulating and releasing hormones passes through the system and is delivered from the hypothalamus to the pituitary. The corticotrophin releasing hormone stimulates the ACTH. Thyrotropin releasing hormone stimulates TSH. GnRH stimulates LH and FSH. And GHRH, or growth hormone releasing hormone, stimulates GH, growth hormone. Dopamine inhibits prolactin. As you all know, the most of the hormones in the body works either by feedback mechanism, positive feedback or negative feedback, but dopamine works in atonic inhibition by dopamine. So the release of dopamine inhibits prolactin. And somatostatin inhibits both TSH and the growth hormone. Next. Before we dig deep into the disorders of the pituitary gland, we will talk briefly about each disorder. Posterior pituitary gland disorders. ADH hormone, increased level of this hormone causes syndrome of inappropriate ADH secretion. It increases blood pressure, it decreases urinary output, and it causes edema. Decreased level of ADH hormone causes diabetes insipidus. It dilutes the urine and increases urine output. Increased level of oxytocin precipitates childbirth and causes excess milk production. and decreased level of oxytocin, prolonged childbirth, and causes diminished milk. Next. The anterior pituitary gland disorders, increased level of growth hormone causes gigantism in childhood and acromegaly in adulthood, and decreased level of this hormone causes dwarfism and premature aging. Increased level of ACTH hormone causes Cushing's disease, and decreased level of ACTH hormone causes Addison's disease. Increased level of TSH hormone causes goiter, and increased heart rate, blood pressure, and Graves' disease. And it increases the base metabolic rate. Decreased level of this hormone decreases the base metabolic rate, decreases the heart rate, cardiac output, and blood pressure. Increased level of prolactin causes amenorrhea, which is cessation of menstruation, and causes hypothyroidism. And decreased level of this hormone causes small amounts of milk. Next. So first we will talk about prolactin hormone. Prolactin hormone regulates blood production in mothers. It works, as I've mentioned before, under inhibitory control from the hypothalamus. The prolactin feedback on hypothalamus works by, if the prolactin level increases, it increases the dopamine production, so the dopamine can inhibit prolactin production. And many other substances also affect prolactin release, such as VIP, oxytocin, and TRH. And the most important one of them is thyrotropin releasing hormone. بس على اللخبطة في شيء ربطت فيها. Thyrotropin releasing hormone, which is elevated in hypothyroidism. When the patient has hypothyroidism, this makes a positive feedback on the hypothalamus to increase TRH production, which increases the TRH production, and TRH production predisposes to an increased level of prolactin. So hypothyroidism predisposes to hyperprolactinemia. So we can say that hypothyroidism is considered a differential diagnosis for hyperprolactinemia, and we also should screen for TSH level in hyperprolactinemia suspected patients. Next. Prolactin in pregnancy. Estrogen level increases in pregnancy, and estrogen stimulates prolactin release. So so this will lead to marked increase in lactotrophs during pregnancy, and this will cause a physiologic increase in the pituitary gland size. Prolactin also inhibits GnRH release, which stimulates the production of LH and FSH hormones and lead to cessation of menstruation and ovulation in pregnancy. Next. Pituitary adenomas. One of the most important clinical correlations of prolactin physiology is pituitary adenomas, which are tumors of any cell type anterior pituitary, and it may result in increased secretion of the hormone or decreased secretion of the hormone if the tumor was non-functional. And the most common secreting tumor is prolactinoma. And of course, the type of hormone depends on which cell type has caused the adenoma. For example, adenoma caused by lactotrophs causes hyperprolactinemia, and if it's caused by thyrotrophs, it will cause central hyperthyroidism. Corticotrophs causes Cushing's disease, and somatotrophs causes acromegaly. There are general signs and symptoms that any, no matter which cell type causes the adenoma, these signs and symptoms will result, such as headaches, bitemporal hymenopsia, and compression of the optic chiasm. Bitemporal hymenopsia is a special type of visual defects in which the patient cannot see on the outer portions of both his visual fields. Next. So hyperprolactinemia. Hyperprolactinemia is defined as a serum prolactin concentration that is repeatedly more than 20 nanogram per ml, and the normal level of prolactin is less than 20 nanogram per ml. So this increase is termed hyperprolactinemia, and this is the most frequent functional abnormality of the pituitary gland. There are prolactinoma causes or prolactinoma-related causes to hyperprolactinemia and non-prolactinoma causes of hyperprolactinemia, such as drugs that are dopamine antagonists, such as certain antipsychotics and metoclopramide and verapamil, which is a calcium channel blocker. Diseases of the hypothalamus or pituitary stalk that interfere with production or transport of dopamine, and thus removing the negative inhibition on prolactin production, such as sarcoidosis or trauma. Pregnancy or estrogen use, and as I've mentioned before, the pregnancy is the most common new cause of physiologic hyperprolactinemia. Orgasm also causes hyperprolactinemia, so we recommend patients to abstain from sexual intercourse for 24 hours prior to prolactin test. And hypothyroidism. And I've mentioned before, we should check TSH level when we suspect a patient with hyperprolactinemia before we start to treat him. And the signs and symptoms of hyperprolactinemia in women is amenorrhea because of the lack of GnRH, LH, and FSH, and galactorrhea, which is a milky nipple discharge unrelated to the normal milk production in breastfeeding. And in men, we see hypogonadism, decreased libido, impotence, infertility, gynecomastia, but we do not usually see galactorrhea because there is no enough breast tissue. Next. Prolactinoma is the most common hormone-secreting tumor. It causes the general symptoms that any adenoma can cause, such as headache, vision loss, and it rarely predisposes to seizures. In women, it causes amenorrhea and fractures because of low bone density, and in men, it causes loss of libido and impotence. And the diagnosis is made by serum prolactin and CNS imaging, and we usually the best modality for CNS imaging is MRI. Pattern of prolactinoma growth. Prolactinomas are usually less than 1 centimeter in size, and if they are less than 1 centimeter in size, we call them microadenomas. But they can also be macroadenomas, causing visual field defects by compression on the optic chiasm. Prolactin levels generally correlate with tumor size, so a prolactin level more than 100 nanogram per ml is related to macroadenomas. So we have to suspect macroadenomas if we see a repeatedly prolactin level more than 100 nanogram per ml. But so if we see a macroadenoma with only mild hyperprolactinemia, then it is probably not a prolactinoma, because here we can see a disproportionate relationship between prolactinoma and the prolactin level. And maybe this will be due to pituitary stalk compression because of other tumor or a pituitary stalk disorder itself. The treatment of prolactinoma, there are more than one option for prolactinoma treatment. It includes surgical resection, medical treatment, and observation. The indications for surgical or medical treatment include tumor size, if it is a macroadenoma more than 1 centimeter we usually use the surgical option, especially if it comes with neurological symptoms. Galactorrhea affecting a patient's quality of life is also an indication for surgery, and women with impaired fertility is also an indication. However, macroadenomas usually do not grow to more than 1 centimeter. So usually they are macroadenomas. So observation alone can be an appropriate option for certain groups, such as menopausal women and premenopausal women who do not desire fertility. Prolactinomas are extremely sensitive and responsive to medical treatment for most patients. So we use usually dopamine agonists. So dopamine can be synthesized and secreted and inhibit the prolactin secretion or excessive secretion. The first-line treatment for prolactinoma is cabergoline, and the second line is bromocriptine because it causes more nausea and orthostatic hypotension than cabergoline. Surgery is usually done through transsphenoidal surgery, and it is only used when the patient cannot tolerate drug therapy or when it is ineffective. And radiation is usually reserved for post-surgical cases to eradicate any remaining tumor. And the follow-up is usually done through MRI, as I have said before. Next. Dopamine antagonists. Dopamine antagonists are considered one of the causes of hyperprolactinemia because they inhibit dopamine. And dopamine cannot exert its inhibitory effect on prolactin. So this will cause an increased level in prolactin level and predisposes to hyperprolactinemia. Next. Hypopituitarism is caused by damage to anterior pituitary gland. It can be caused either by mass effect and through non-functional adenoma or craniopharyngioma, which is a benign tumor, and ischemia, brain injury, and hemorrhage. ACTH deficiency. In ACTH deficiency, there will be no loss of aldosterone, so there will be no salt wasting, and there will be no hyperpigmentation, as seen in primary adrenal failure. We talked about TSH deficiency and hypothyroidism, and FSH-LH deficiency and hypothyroidism. Next. Craniopharyngioma is a benign tumor. It usually occurs in children 10 to 14 years old. Its symptoms result from compression, headache, and visual field defects, and behavioral change from frontal lobe dysfunction. Next. Radiation. Radiation is usually reserved for post-surgical cases to eradicate any remaining tumor. But we can also use it to treat some head and neck tumors. Next. Pituitary apoplexy is a neurosurgical emergency. It is caused by hemorrhage into a pituitary mass. So we suspect apoplexy in a patient who presents with severe headache, nausea and vomiting, visual defects, or altered mental status. It's urgent. It has to be urgent recognition for this condition, and the treatment is necessary to prevent life-threatening hypertension from secondary adrenal insufficiency. Next. Next. Sheehan Syndrome. Sheehan Syndrome is caused when pituitary gland enlarged in pregnancy. It is a postpartum hypopituitarism caused by ischemic necrosis due to blood loss and hypovolemic shock during and after childbirth. It always involves the anterior pituitary and sometimes also affects the posterior pituitary, but it rarely causes central diabetes insipidus. And in mild cases, the syndrome presents with failure to lactate and eventual postpartum amenorrhea. And in severe cases can manifest with symptoms of adrenal insufficiency or hypothyroidism. Next. Treatment to hypothyroidism is by hormone therapy, corticosteroids, thyroid hormone, growth hormone, estrogen, and testosterone. Next. Any questions so far? اوكي يعطيكم العافيه. جواد.
السلام عليكم.
تفضل.
السلام عليكم. أنا زميلكم جواد الخزعلي، وحكمل معكم جزء من محاضرة Pituitary Gland Disorders. زي ما بتعرفوا وزي ما شرح زميلي محمد، عندنا بجسم الإنسان بالدماغ جزء اسمه الهايبوثالاموس، والهايبوثالاموس فيه أوزموريسبتورز، وهاي الأوزموريسبتورز هي عبارة عن سنسرات للأوزمولاليتي. والأوزمولاليتي هي concentration of all chemical particles found in the fluid part of the blood أو السيرم. ومثل ما بتعرفوا أهم البارتيكلز اللي بتحدد لنا هاي الأوزمولاليتي هي الجلوكوز والبلود يوريا نيتروجين والصوديوم اللي حنركز عليه اليوم بالمحاضرة. وطبعا عشان ما ننسى النورمال بلود أوزمولاليتي رينجز between 275 ل 295 ملي أوزمول بير كي جي. طيب بحالة الديهايدريشن الأوزمولاليتي بتزيد، وهون أول إشي بيعمله الجسم من خلال الأوزموريسبتورز هو إنه يحسسنا بالعطش، فبنشرب مي ومنعدل الأوزمولاليتي. إذا هاي الميكانيزم ما كفت، الأوزموريسبتورز نفسها حتحفز لي ستراكشر بالهايبوثالاموس اسمه السوبرا أوبتيك نيوكلير، واللي هو عبارة عن تجميعة من خلايا مميزة اسمها ماجنوسيلولار نيوروسكريتري سيلز أو الMNCs. السوبرا أوبتيك نيوكلير بتحفز البوستيريور بيتويتري جلاند من خلال السوبرا أوبتيك هايبوفيزيال تراكت، فبتفرز لنا هرمون اسمه الأنتي دايوريتيك هرمون أو اسمه الثاني مثل ما حكينا الفازوبريسين. طبعا الفازوبريسين له 2 functions، وهم أول واحدة الفازو كونستريكشن، والفانكشن اللي إلها علاقة بالمرضين اللي حشرحهم اليوم، وهي إنه بيروح على النفرون تحديداً، يعني تحديداً على الكولكتنج داكتس والديستال كونفوليوتد تيوبيولز، وبيرتبط بريسبتور هناك. الريسبتور اسمه الفازوبريسين ريسبتور 2 أو ال AVRP2، وبيحفز الخلايا اللي ارتبط فيها إنه تسوي لي upregulation لبروتين اسمه الأكوابورين، واللي بيسمح بنقل الواتر بارتيكلز لحالها، ولازم نحط خط تحت كلمة لحالها من اليورين للبلد. نتيجة لهذا الإشي طبعاً بيسوي لي ديليوشن للبلد وبيخفف البلد أوزمولاليتي. وهيك بتكون وصلتنا الفكرة من أول مرض ححكي عنه اليوم، وهو ال SIADH. ال SIADH أو Syndrome of Inappropriate ADH Secretion is a condition characterized by excess ADH secretion from the posterior pituitary gland that leads to retaining too much water by the body. Next. طيب اللي بالبداية حكينا عنه شو الميكانيزم الطبيعية لل ADH، هسه بدنا نوصل للي مش طبيعي اللي هو زيادة الأنتيدايوريتيك هرمون. زيادة الأنتيدايوريتيك هرمون شو بتعمل؟ بتزيد الأبريجوليتنج للأكوابورينز. الأكوابورينز بتزيد لي الفري ووتر ريتنشن. نتيجة لهذا الإشي بزيد عندي الانترا فاسكولار فوليوم، ونتيجة كمان لهذا الإشي بزيد عندي هايبوناتريميا، ونوع هاي الهايبوناتريميا هي ديليوشنال هايبوناتريميا. ودكتور في ميكانيزم ثانية بس أنا ما حطيتها بالسلايد لأنه مش متأكد منها، إنه زيادة ال ADH بتعمل نيجاتيف فيدباك للألدوستيرون، فكمان بتعمل لي هايبوناتريميا، بس زي ما حكيت يعني خفت تطلع غلط. next. طيب أول إشي بدنا نحكي عن أسباب ال ADH ال SIADH. أسباب ال SIADH ممكن تكون تيومرز زي السمول سيل لانج كارسينوما والبرين تيومرز والبلادر تيومرز. وممكن CNS disorders تعمل لي SIADH زي الستروك، التروما والانفكشنز. أي لانج ديزيز ممكن يعمل لي SIADH زي التيوبركلوسيس والنيومونيا. وممكن ثايرويد أو باراثايرويد هرمون ديفيشنسيز تعمل لي SIADH. ممكن ميديكيشنز زي selective serotonin reuptake inhibitors تعمل لي SIADH وهايبوناتريميا. والمورفين والديزموبريسين والكلوروبرومايد والأوكسيتوسين كلهن أثبت إنهن بيعملن SIADH. والبرين سيرجريز الميكانيزم مش معروفة بالضبط، بس في دراسات تحكي إنها بتعمل SIADH. Next. طيب شو الساينز اند سيمبتومز؟ SIADH بالساينز اند سيمبتومز بيشبه شوي dehydration، بس عشان نلخصهم بشكل عام ممكن يكون في lethargy weakness، ممكن نشوف confusion or changes in neurological status، ممكن يكون في cerebral edema وفي muscle cramps و decreased urine output. ممكن يكون في weight gain وهاي الويت gain بتكون بدون edema. ممكن يكون في hypertension ونوجا وvomiting. طيب في بالحالات السيفير ممكن نلاقي seizures وكوما، وإحنا بنصنف الحالات لسيفير ومايلد تو مودريت لأنها بتفرق معنا بالعلاج. next. الدياجنوستس للSIADH بيكون by exclusion of other causes of hyponatremia. طيب كيف يعني؟ الهايبوناتريميا أول إشي لما نشوفها بنقسمها لثلاث أقسام، يا هايبرتونيك هايبوناتريميا، يا ايزوتونيك هايبوناتريميا، يا هايبوتونيك ايزوناتريميا. أول إشي بنستثني الأسباب الهايبرتونيك زي الهايبرغلايسيميا، وبعديها بنستثني الايزوتونيك كوزز زي الهايبربروتينيميا والهايبرليبيديميا ممكن يعملوا لي SIADH. بعدين بنبلش بالأسباب الهايبوتونيك هايبوناتريميا، وهي نفس الإشي كمان بنقسمها لثلاث أجزاء بالديفرنشال دياجنوستس. ممكن تكون هايبرفوليميك، هايبوفوليميك ويوفوليميك. بعد ما نستثني الهايبرفوليميك والهايبوفوليميك زي الديهايدريشن والكونجستيف هارت فيلير والليفر ديزيزز واستخدام الدايوريتكس زيادة، بعديها بنبلش نفكر بالأسباب اليوفوليميك هايبوتونيك هايبوناتريميا زي البوست اوبراتيف والهايبوثايرويدزم والSIADH. طيب بس في فحوصات بتساعدني غير عن إنه في هايبوناتريميا، في فحوصات بتساعدني إني أشخص الSIADH. بالSIADH ممكن أشوف السيرم أوزمولاليتي أقل من 275 ملي أوزمول بير كي جي، وممكن اليورين أوزمولاليتي أكثر من 300 ملي أوزمول بير كي جي. اليورين صوديوم كونسنتريشن ممكن تكون أكثر من 40 ملي إكوفالنت بير لتر، بس هاي طبعا للإنسان اللي عنده normal dietary salt intake. ممكن أشوف low blood urea nitrogen. الكرياتينين بشكل عام بالSIADH بيكون normal. ممكن أشوف hypouricemia، ممكن أشوف hypoalbuminemia. next. التريتمنت للSIADH أول إشي بنسوي تريتنج للأندرلاين كوز بغض النظر كان تروما أو تيومرز أو أي واحد من الأسباب اللي ذكرناهن قبل. بعدين بنحكي للمريض يعمل لحاله واتر ريستريكشن، نحكي له ما يشرب أكثر من 1.5 لتر بير داي. بعدين زي ما حكينا تصنيف السيمتومز لمايلد ومودريت بعدين سيفير عشان تفرق معنا بالتريتمنت كيف، لأنه بالمايلد ومودريت ممكن نعطيهم نورمال سلاين، أما بالسيفير سيمتومز لما نشوف سيجرز وكوما وفوميتنج نعطيهم 3% سلاين أو هايبرتونيك سلاينز وفايبتانز. بالمايلد ومودريت بنعطيهم لوب دايريتكس وممكن ديميكلو سايكلين. لوب دايريتكس ممكن نعطيهم بيوميتانايد. next. هسه بنوصل للمرض الثاني اللي له علاقة بالADH اللي هو الديابيتس insipidus. الديابيتس insipidus ثواني بس. طيب الديابيتس insipidus is defined as the passage of large volumes of dilute urine، يعني ممكن تكون أكثر من 3 liters per 24 hours. وعلى عكس SIADH بيكون اليورين osmolality أقل من 300 ملي أوزمول بير كي جي. وهنا في 2 غلط، لازم 4. It has the following 4 major forms. في 4 types يعني للDI. ممكن أول واحد يكون central DI اللي هو neurogenic pituitary بين قوسين، يعني المشكلة بالpituitary gland ممكن تكون، وبتكون characterized by decreased secretion of antidiuretic hormone، يعني المشكلة بالquantity تاعت ال ADH، واللي هو اسمه الثاني arginine vasopressin. والنوع الثاني اللي هو النفروجينيك دي اي. النفروجينيك دي اي المشكله مش بالاي دي اتش، المشكله يا باستقبال الاي دي اتش، او ممكن تكون يعني بالكدني، او ممكن تكون الاكوابورنز صار فيها ميوتيشنز او شيء يمنعها من انها تنقل المي او يخرب عليها هاي الوظيفه، وبيكون characterized زي ما احنا كاتبين by decreased ability to concentrate urine because of resistance ممكن كمان to ADH action in the kidney. والنوع الثالث اللي هو gestational DI. بيكون بالgestational DI البلاسينتا releases vasopressinase اللي هو يعني من اسمه بيكون عكس وظيفة الفازوبريسين وبريكس داون ADH. بالgestational DI بداية الريليسنج للفازوبريسيناز بتبلش من الأسبوع الثامن، وبتظلها للثيرد ترايمستر. بس في دراسات أثبتت إنه السيمتومز تاعت الDI هاي ممكن تظلها لشهرين بعد الليبر. النوع الرابع اللي هو الديبسوجينيك DI. الديبسوجينيك DI is characterized by drinking too much water، وهي نوع يعني يونيك من الDI لأنه على عكس الباقي بيكون السيرم osmolality is decreased in it على عكس الباقي، يعني بتشبه ال SIADH. next. طيب الكوزز للDI ممكن تكون pituitary or hypothalamic tumor، ممكن نفس الشيء تروما أو سيرجري تعمل لي DI، ممكن meningoencephalitis، وممكن تكون يعني في familial يعني، وبالعادة بتكون autosomal dominant. signs and symptoms of DI polyuria وبوليديبسيا ونكتوريا وديهايدريشن. الdiagnosis of DI ممكن نطلب لهم MRI، ممكن نعمل لهم water deprivation test، ممكن نطلب لهم CBC عشان نستثني الأسباب الثانية، يعني ممكن نستثني الDM من خلال CBC serum electrolytes concentrations and glucose level. وبنطلب لهم بلازما ويورين اوزمولاليتي لازم نشوفه عشان نحدد. اليورين اوزمولاليتي لازم تكون أقل من 200 ملي أوزمول بير كي جي بالدي اي، والبلازما اوزمولاليتي بالدي اي بتكون أكثر من 295 ملي أوزمول بير كي جي. يعني بشكل عام البلازما is hyper osmolar على عكس الاس اي دي اتش. التريتمنت ثواني
جواد بدنا نطفي ونعود نفتح كمان مرة لأنه بتدخل.
تمام. أفوت على نفس الرابط.
دكتور رح يخلص الزوم، بدنا نفوت كمان مرة على نفس الرابط.
اوكي تمام.
دكتور أكمل؟
كونتينيو.
وصلنا لعند التريتمنت للدي اي. أول إشي بنسوي كوركشن للديهايدريشن للإلكترولايت إمبالانسز، بعدين بنسوي ريبليسمنت للأي دي اتش أو الفازوبريسين، وبعديها بنعطيهم ديزموبريسين أسيتات intravenously، وممكن نعطيهم thiazides to deplete sodium and increase renal water reabsorption. next ريما. هذا السلايد فيه مقارنة بين الدي اي والاس اي اي دي اتش، ممكن يساعدكم بالحفظ، بس احفظوا واحدة والثانية العكس. next. طيب وصلنا لآخر سلايد حكي عنه أنا اليوم، واللي هو عن هرمون الأكسيتوسين أو اللي بيسموه اللوف هرمون. طيب الأكسيتوسين هو نيوروبيبتايد ونيورو ترانسميتر، وريليست into the bloodstream as a hormone in response to stretching of the cervix and uterus during labor. يعني during labor وممكن يصير له stimulation during breastfeeding. طيب the numbers of oxytocin receptors increased markedly during later part of pregnancy. عشان هيك الأوكسيتوسين is also used as a medication to facilitate and speed up the process of childbirth. Due to its similarity to vasopressin, it can reduce the excretion of urine slightly. وعشان هيك إحنا مرات نستخدمه كأنتي-diuretic. A lack of oxytocin in a nursing mother ممكن يسوي لها مشاكل بالميلك ejection reflex وبصعب عليها البريست feeding. At present, the implications of having too much oxytocin are not clear, but high levels have been linked to benign prostatic hyperplasia عند الرجال, which may cause difficulty in passing urine. أنا هيك خلصت دكتور. هسه رهف كأنه.
السلام عليكم، أنا رهف راح أكمل عن ال growth hormone and the diseases related to it. ال growth hormone or as known as somatotropin is secreted by the anterior pituitary cells by cells called somatotrophs. Growth hormone is responsible for the growth of almost all tissues, whether directly or indirectly via the insulin-like growth factor 1. Normally, the hypothalamus secretes growth hormone-releasing hormone in bursts throughout the day, and this amount may increase due to low blood glucose level, increased exercise, sleep, or stress. The growth hormone-releasing hormone goes into the hypophyseal portal system, which is a capillaries network between the hypothalamus and the anterior pituitary. The growth hormone-releasing hormone binds to the surface protein on somatotroph cells of the anterior pituitary gland and then release the growth hormone. There is 3 ways to limit the amount of growth hormone. The first one is too much growth hormone-releasing hormone signals the hypothalamus to stop making more. The second way, growth hormone reaches tissue like liver and they make somatomedian C or insulin-like growth factor 1, which signals the anterior pituitary to stop producing growth hormone. The third way, growth hormone and IGF-1 signal the hypothalamus to produce somatostatin, which its role is to signal the anterior pituitary to stop producing growth hormone. Growth hormone has direct and indirect effects. Indirect effect, growth hormone stimulates cellular metabolism and leads to organ growth. For example, in liver, more glucose released into the blood. In the muscles, the body retains nitrogen, leading to more muscle growth. And in bones, osteoblasts are stimulated, causing the bone to thicken. Another direct effect is increasing insulin resistance, making it harder for cells to take in glucose, which leads to an increase in the blood insulin level, and this is called a diabetogenic effect. The indirect effect of growth hormone is stimulating a certain tissue like liver to produce IGF-1, which promotes cellular metabolism, prevents cell death, and helps cells divide and differentiate throughout the body. Next. So the first 2 diseases I'm going to talk about is caused by increasing secretion of GH, which they are gigantism and acromegaly. First of all, gigantism is a rare disorder characterized by abnormal linear growth during childhood due to growth hormone excess while the epiphyseal growth plates are still open. Children with gigantism present with tall stature, increased growth of the distal limbs, for example, hands, feet, fingers, toes, tumor mass symptoms like headaches, visual changes, features of hypopituitarism, progressive macrocephaly, coarse facial feature, frontal posing, progangism, obesity, risk factor associated with an increased incidence of pituitary tumors, multiple endocrine neoplasia type 1, MIN1, Mukin-Albright syndrome, Kearney complex, neurofibromatosis, tuberous sclerosis. Diagnosis of gigantism by increased serum IGF-1, increased GH after oral glucose tolerance test confers pituitary gigantism. After a biochemical diagnosis, we may use MRI to check for pituitary masses. CT if MRI is negative to exclude other GH secretion tumor like pancreas, adrenal gland, ovarian. Next. Treatment of gigantism by transsphenoidal surgery for pituitary adenoma excision. Medical therapy, we use somatostatin analogs like octreotide or GH receptor antagonists like bigvisment. Complications of gigantism are carpal tunnel syndrome, cardiovascular disease, heart failure, which is the most common cause of death, hypertension, osteoarthritis, endocrine disorders like hypogonadism, diabetes, hyperprolactinemia, benign tumors like uterine leiomyomas, prostatic hypertrophy, colonic polyps. Next. Acromegaly, which is similar to gigantism but in adult. It's also a hormonal disorder where there is excess growth hormone, which caused continued growth of the extremities in adults, leading to a large face, hands, feet. It's almost caused by secreting pituitary tumors, somatotroph adenoma. Overall prevalence is about 3 to 4 million per year, and it's usually sporadically, but also may happen due to mutation and cause a familial acromegaly, typically mutation in the AIP gene. Next. Signs and symptoms of acromegaly occurs over years, so the patient, him or herself, may not see the changes, but they may feel changes in their shoe size or ring size, for example. So they may have an acral growth, which is growth in bones, hands, feet, or lower jaw, protrusion of forehead, soft tissue swelling in hand, feet, face, and tongue, increased size of organs, and excessive sweating. And also these changes can lead to additional health problems, like as we mentioned in gigantism, carpal tunnel syndrome, because of the increased pressure of on the nerves from muscle growth, diabetes mellitus from the diabetogenic effect of a growth hormone, congestive heart failure due to enlargement of the heart, gastrointestinal cancers from colon polyps outgrowth in the large intestines. Next. Causes of acromegaly is pituitary adenoma, and usually it is a benign tumor. In this case, these cells continuously make excess growth hormone, and this leads to excess insulin like growth factor 1. Rarely, acromegaly can result from hypothalamic tumors that release too much growth hormone, releasing hormone, and it's also rarely associated with a congenital syndrome like multiple endocrine neoplasia type 1, which is called Werner syndrome, and that affects the parathyroid, pancreas, and pituitary. Next. The diagnosis of acromegaly, if we test for the GH levels, we can exclude acromegaly if it is if the level are undetectable, but if it is detectable, we can't diagnose acromegaly. So the most important test is IGF-1. If IGF-1 is normal, no further test is required. But if there is a raised in IGF-1, we go to a glucose suppression test to confirm the acromegaly. In glucose suppression test, we give the patient 75 grams of glucose and measure the amount throughout 2 hours, first 30 minutes, 60 minutes, 90 minutes, and 120 minutes. And the GH value must be less than 1 microgram per liter. If it's more, 1 or more, it's acromegaly. Next. We also may use visual field examination because if they're complaining of bitemporal Hymenopia. We use MRI scan to check for pituitary adenoma. We also may do pituitary function and prolactin levels because it shows a mild to moderate hyperprolactinemia. Next. Treatment depends on the underlying cause. First, surgery in case of pituitary adenoma. And if pituitary surgery fails to normalize GH levels, so we use radiotherapy. Also, we may use medications like somatostatin analogs to limit GH production, or GH receptor antagonists to stop GH from binding to target tissues. Next. Now, dwarfism, which is the opposite for gigantism, we can say, or achondroplasia. It's a disorder in children characterized by stunted growth. It's generally defined as an adult height of 147 centimeters or less. Etiology of dwarfism is reduction in growth hormone in infancy or early children. It's rare and it's tend to be more common in boys. Etiology of it: deficiency of IGF-1 somatomedian C, deficiency of growth hormone releasing hormone from hypothalamus, panhypopituitarism. Next. Signs and symptoms: stunted skeletal growth, head becomes slightly larger in relation of the body, normal mental activity without any deformity, maximum height approximately 3 feet. Reproductive system is not defected due to lack of growth hormone. Children with growth hormone deficiency might be overweight, as growth hormone also helps to control the amount of fat under the skin. Next. Rima, next. Diagnosis: most cases of achondroplasia can be diagnosed before birth through using an ultrasound in the later stages of pregnancy. Ultrasound can show shorter than average arms and legs, or whether the baby's head is larger than average. It can be diagnosed using a blood test to measure the level of growth hormone in the blood, that's called growth hormone stimulation test. Next. Treatment. The goal of the treatment is to maximize function and independence. Dwarfism's treatment don't increase stature, but may alleviate problems caused by complications. Growth hormone deficiency is treated with injection of synthetic version of the hormone each day. The dose will change with the age. Side effects of growth hormone injections are rare, such as headache, vomiting, problem with eyesight that can be stopped by reducing the dose. Surgical procedures that may correct the problem with bones in people with disproportionate dwarfism. Next. Thank you. Any question? Muhammad?
Marhaba. Carry on where we stopped. We're going to talk about the adenocorticotropin hormone secreting pituitary adenoma. The adenocorticotropic hormone stimulates the adrenal gland cortex secretion of mineral corticoids like aldosterone from the zona glomerulosa and glucocorticoids like cortisol from the zona fasciculata. Cortisol is a stress hormone. It's vital to survive. It helps to maintain blood pressure and blood glucose levels as it raises glucose levels in the bloodstream. Aldosterone maintains electrolyte water balance as it's also stimulated by the renin-aldosterone-angiotensin system. This mechanism by which renin converts angiotensinogen, and in the end we'll have angiotensin 2 activating aldosterone, which lead to reabsorb in the water and sodium and thus increased by the blood volume and blood pressure. Next. Dr. Hala, we have two definitions, one for the Cushing syndrome and one for the Cushing disease. The Cushing syndrome is the production of excess cortisol by the adrenals. However, the Cushing disease, it's excess cortisol in blood due to the ACTH secreting pituitary adenoma.
We're going to talk about the etiology of Cushing disease. The most common exogenous cause is iatrogenic. For example, a patient taking high amount of cortisol. This will lead to a decrease in the ACTH and thus bilateral adrenal atrophy. As for the most common endogenous cause, it's ACTH secreting pituitary adenoma or paraneoplastic ACTH secretion, like small cell lung cancer, and it's the most common cause in patients over 60 years old. We'll see in Cushing disease increase in cortisol, increased urinary free cortisol, changes like thinning, stria, growth retardation in children, obvious findings like moon face, buffalo hump, hirsutism, amenorrhea, hypertension, and osteoporosis through the DEXA scan. Next. For the diagnosis, we will have an increase in the plasma cortisol and urinary cortisol. Nowadays, the urinary cortisol is better than the plasma as it's not very beneficial. والتست بيكون 3 times more than the normal amount. We have dextromethasone suppression test 1 milligram normally. Normally it's suppressed. إذا كان عندنا ما في suppression with overnight low dose بيكون عندنا Cushing. As for the bilateral inferior pituitary sinus sampling, it's the best way to differentiate between pituitary from ectopic ACTH dependent Cushing disease. Next. دكتور هذا دياجرام ببين لنا الدكسترا ميثازون سبريشن تيست وكيف نعرف اذا تو دايجنوز كاشينج او مش كاشينج، واذا كاشينج نعرف اذا ACTH dependent او independent. هلا for the ACTH independent ممكن يكون عندنا adrenal cause، ممكن يكون عندنا مثلا adenoma, carcinoma or hyperplasia. إذا it's normal or high, it's ACTH dependent and it may be pituitary or ectopic. Next. هل هذا it's a more detailed diagram to know whether it's ACTH dependent or not. If it's independent, it's gonna be under 10 and we'll check for CT or MRI adrenals. في عندنا تست ثاني اللي هو DHEA dehydroepiandrosterone test. إذا it's high then it reflects adrenal carcinoma, but it's unlikely in adults. هلا إذا كان ال ACTH normal or high يكون ACTH dependent. Thank you for listening.
اوكي، يعطيكم العافيه جميعا.
الله يعافيك دكتور.
اوكي خلينا نعمل شير سكرين. اذا بتعمل لي بس اني هوست دكتور او ريما.